and in neuromodulation from open loop to closed loop stimulation. So I think that the bottom line is we want to present new surgical options for patients. So, in general, as you all know, I will basically classify things as lesional epilepsy, where we have an MRI apparent or suspected lesion, and of course, a non-lesion epilepsy, which is not associated with any apparent structural abnormality. And I think that makes a big difference, especially in areas such as the insula. And that's why we really have to consider all the options which are available today to approach this very, exciting and interesting areas. Of course, in terms of lesion, we know our, traditional hippocampal sclerosis. There is actually a lesion which is associated, and that's why the success rate is really very high. Okay, but of course, this is not the case, and in fact, at UCLA, we see very few hippocampal sclerosis cases anymore. Either they are done at the community, or they simply are not as many as we have suspected. So in terms of our workup, and this would be relevant to our approach to the insula, one of the key elements is really the semiology, the nature of the beginning of the seizure. I think especially the French tradition has been really magnificent in using the semiology. Of course, we have the video EEG that you know about, the MRI, the PET scan, the SPECT, the neuropsychology. One interesting tool that unfortunately is not available very much and not widely used is the magnetic source imaging, or the MEG. And I'll talk about how it can be used, especially in areas such as the insula. We can do source analysis computations on the EEG, even, which is a second maybe surrogate for MEG. We can, in very advanced centers, can combine fMRI with EEG to actually get an fMRI which is locked in time to the interictal spikes or the ictal event on the EEG. And we have, of course, subdural electrodes and depth electrodes, or SEEG, okay? And you can see just an example, this is a case where, there weren't much clues in terms of structure, but there were actually, this is a MEG, or magnetic source imaging, which really tells you that something is happening in the opercular, frontotemporal, possibly anterior insular area. And the advantage is that we cannot really go ahead and do anything like a resection or ablation based on this, but it can direct our SEEG investigations, so we can create a hypothesis and then implant the electrodes accordingly. So, here is the insula. I mean, you have heard probably a wonderful lecture on the anatomy. I wouldn't be able to really do better, but you can see how complex the structure is. What I really like is this paper by Revlan, who has done, obviously a lot of work in the insula. And this is really the anatomy of ictal semiology. And I think in the insula, it is really key. And I think in this paper, in 2021, they divide this insula into 5 areas. And I find this very useful. One is a dorsal anterior pattern, where you don't have an aura sometimes, or you can have an aura of fear, or sometimes hypermotor behavior. The classical ventral, part of the anterior insula, which is more associated with epigastric sensation, gustatory, emotional aura, or sometimes manual and oral alimentary automatism. You can see immediately that this anterior insula has a semiology which is very similar to temporal lobe epilepsy, or medial temporal lobe epilepsy. And that's, of course, has to do with the connectivity of the insula. I will not repeat, I'm sure you heard about it in the previous session, but it is really key. The insula, for instance, has very strong bidirectional connection to the amygdala. So what we can identify as temporal lobe, even the epigastric, the fear, all these things which we have known in temporal lobe epilepsy, we understand that they may be emanating from this network which involves the anterior insula. And then you have, the dorsal mid-anterior. There you start to see, frontal opercular signs, very often laryngeal sensation. Patients have feeling in the throat, some tightness. Once you move posteriorly, you are moving to somatosensory signs, pain, more sensory, and in the ventral part, part like in the posterior insula, you can even get auditory semiology, which can be, confused with Heschel gyrus. So again, just the semiology itself can direct you where to put your electrodes, okay? So I find this extremely useful. So in the SEEG, okay, we in the United States, we used to call this depth electrodes. And in fact, a lot of the pioneering work have been done by my predecessor, Paul Crandall, over 50 years ago. And it was called depth electrode. In parallel, of course, there is a very distinguished French tradition where it was called SEG. And then once certain people moved from Europe to the US, the name SEG stuck, and even I have to use it, or I always use the terminology of depth electrode. So at UCLA, we have done it for obviously many years, and we have the electrodes which we have for the SEG, has those macro contacts, and we also have, micro wires, at the distal end, which enables us to look not only at single neuron activity and multi-neuron activity, but also at high frequency oscillation, which were first identified really, the HFOs were identified using those micro wires, in the medial temporal lobe. This is a classical hippocampal structure in the entorhinal. And you have the patient obviously, available until they have seizures in the unit. And what we have essentially is the ability to record from those micro wires. We can record, you can hear actually action potentials. You can hear the firing, of the neurons, and I'll talk about it at the end in terms of what is enabled in research. So, our approach, and this will be relevant to the insula, for depth electrode has been traditionally orthogonal, meaning that if you look at the Laxell stereotactic frame, we don't even have to use the arc of the Laxell frame. We can just use, the lollipops on the side, because there is a fixed distance between those lollipops and the center. So this can be done very, very, very quickly. We can do a case with 10 electrodes in 2 hours, in this fashion. Of course, once we want to approach the insula, things get a bit more complicated, and we have to use an oblique approach occasionally. If we summarize, we recently summarized our experience with stereo EEG in this series. So in general, from those years, we implanted 218 patients. We had 10 electrodes per patient, 12 days average monitoring. We had, 2,200 hybrid micro wireless electrode with, close to 20,000 micro wires, okay? And, it's a relatively safe procedure, as you all know. We had one case of infection, one case of, hemorrhage that we could see, but no permanent neurological deficit. But what we saw very clearly, and this will be relevant to the insula, that if you look at the at this period of time from 1993 to 2013, 159 patients with SEEG, and we can only offer resection to about half of them, and we couldn't treat the rest of those. Now, from 2014, when RNS got in, we could start offering people resection or RNS in cases that we had, more than one focus, and I'll talk about it, when we move on, okay? but actually we have done since then less resection. So I'm a little worried because the residents are losing their touch of open anatomy, and I think craniotomy obviously is a very important tool, but we have to really use what we can use for these patients, okay? So in terms of an orthogonal approach to the insula, in the dorsal anterior part, you can, if you want to really be orthogonal, you're obviously limited, and dorsal you can approach. You can approach it orthogonally, and you can see here, this is the anterior insula, right? And you can see our distal end is there, so we can have some contact there. And at the same time, we can sample also neocortex here, at the inferior frontal gyro. So this is one approach. In the mid, we can also sometimes use an orthogonal or semi-orthogonal, a little oblique here, really to get into this area, which is really the dorsal mid-insula. Now, once you get to the posterior, especially to the ventral part, then you have got to use oblique approaches, right? And you can see here, as we approach, this area, and, you can see it here. And when you go further down to the ventral part, you're already close to the posterior insula. You can see here in the ventral part, right? So, you have to use several approaches. Of course, with the ROSA, with the robot, it's become easier to really do it, but I think it can be done almost as fast, with a Laxel frame, if you really know what you are doing. So now, if you notice, this is a very interesting case. What do you notice here? Something was done in the temporal lobe, right? So this is a patient, who in fact, maybe I'll mention him later, but this patient really, presented with what looked like temporal lobe epilepsy. He didn't really have hippocampal sclerosis, but I think we did the initial procedure over 10 or 15 years ago, and we did a temporal lobe resection, which resulted in good initial results. But then, seizures came back, and he developed semiology of tingling in the throat, and we suspected really that something was going on in the insula. It's a long story, but eventually we ended up, putting an RNS there, and I'll talk about it. Here we are dealing with, the dominant insula. So it's not a simple issue to really perform a resection here. And we don't have a tumor, we don't have a lesion, so our approach has to be different. Okay, so if we look at this case, for instance, it's a patient, who is 41-year-old woman, has an aura of tachycardia with anticipation of an event to happen with deja vu once a day, progressing to generalized, tonic-clonic, suspected right temporal, but there were some worrisome signals like autonomic changes, tachycardia, and fear, and we were really debating. The hypothesis was temporal versus insular. So we have, frequent generalization is not very typical of mesial temporal lobe epilepsy. So there were some red flags here, okay? So, in this kind of case, we ended up implanting a really insula at several locations. You can see an orthogonal approach, to the anterior insula and to the opercular area. And you can see here, we're targeting, mid-insula, dorsal mid-insula. The advantage to some extent that we can also, deal with the opercular area. And sometimes this opercular insular system, present in certain ways, and we are not sure that it's really purely insular. So the SCG can give us, details about this. But in this case, actually, we found out by implantation that the seizure actually started actually in the mesial temporal area, actually starting at the temporal pole. And that's probably explained the fact that by uncinate fasciculus, there was involvement of this entire system, but the source was actually in the temporal pole. So it was not really a typical, mesial temporal hippocampal sclerosis picture. It was a more complicated picture than that, Another situation, a boy who is 10 years old, here again, semiology of throat discomfort, okay, retching, okay, immediately suspecting by the semiology that we have a certain problem in the insula. So there was a general left scalp EEG localization, not good enough. The MEG gave sort of general left frontal localization. And actually, he had several heterotopias, both in the frontal, insular, and temporal cortex. So again, in this kind of case, you really need to sample the insula, and you need to really use oblique approaches. It's a very complicated case because it turned out in that case that the seizures were not coming, from the most prominent heterotopia, and it appeared to be regional onset. So this patient is really not a candidate for a focal resection. And you can see again, the kind of, creative approaches that you have to use, because obviously the insula, is a very vascular area, and you have to be quite cognizant of all this complication. I'll very briefly touch upon, what laser can offer us and bring you one example. I don't know to what extent you are using this technology. Again, it's been in the US and we've exported it, out of the US. But the idea, of course, is to implant, a stereotactic optic fiber to deliver thermal energy into that tissue with 3 to 10 millimeter diffusion tips, that 2 or 3 companies dealing with it. This was particularly done with Visualase. At the time, you have to use cooling at the same time. But the idea is that you implant the catheter either in the OR or in the MRI, and then you have real-time MRI thermometry, and you basically cause heat damage to the tissue. So, just in general, as you know, and I'll go very briefly because it's not insular, but, we have treated hypothalamic hamartoma very effectively with this. It really changed the landscape of hypothalamic hamartoma because we can go into areas that have, a lot of function around, and we can block the thermal energy in the MRI getting into the mammillary body or the fornix in this case. And this has achieved, you can see what happens by this thermal energy. Now, and you can see the result here, essentially you get, ablation of the hematoma and really sometimes exquisite seizure-free results. It's been very popular, as you may know, because the hippocampus is sort of made for this, right? And in the same way that you can put in SEEG, electrode to the hippocampus, if you want to look at mesial temporal lobe epilepsy, you can put this and again get essentially see the temperature in the magnet. You can see the temperature in the magnet, and you can get essentially an ablation. What is nice about the technology that it's even, I've used it. Initially, Bob Gross at Emory has done this, and initially I thought it was crazy to try and get a cavernous, angioma, a cavernoma with this, but apparently it's very possible, and actually I've used it on deep lesions, like here in the parahippocampal gyrus. And so it may be very suitable for deep lesions in the insula, as long as you can identify really a lesion. So, here is an example of a 5-year-old boy. It's a patient of my colleague, Dr. Fala, who is a pediatric, neurosurgeon who's done excellent work with epilepsy. And they had a 5-year-old boy who presented with auras of fear. He felt the brain feeling wobbly. There were pain, in the right anterolateral shin, right dorsal forearm, hand. Immediately, there is an insular thing to this question, this pain and sensory direct you, to the sensory or mid-insular area. Fear, well, maybe, you're getting more anterior, you really don't know. But the patient also had a left posterior insular lesion, which we could see on the MRI, suspected it to be focal cortical dysplasia. The PET showed hypometabolism of the left posterior insular and anterior parietal lobe. So you can actually see it here. I mean, it's pretty subtle. That there are some changes here. You can see right here in this area of the posterior insula. And if you look very carefully, at the PET, you compare one side to the other, you see that there is a hypometabolism here. Again, it's very subtle, but, we suspected that here is the problem. So this is really so here, is an insular case that you can actually approach, with the ablation resection paradigm. I think the laser ablation is a fantastic tool exactly for this type of situation. And you can see the approach here, right? You can see here the approach, to the posterior insula. And you can see, in the MRI, you can actually see the temperature. And initially, what is blue is still a reversible lesion. But once you activate the laser at 60%, you start to create a permanent lesion. So you can initially see a spread of the temperature like a 25 or 30, which is obviously not permanent damage. But essentially a heat, essentially what you create with RF, only you do have the imaging in the magnet itself. And you can see here, what is done both on the coronal and, in the axial. So, what happened, with this patient, the patient actually was seizure-free for 3 years, and they took him off medicine. The seizures came back. They started him on medicine, and he's now seizure-free on medicine. Now, you may ask why, and I think the issue is always, what is happening with the network? Is it just the lesion itself? It's cortical dysplasia. We know that there is cortical dysplasia. It's the periphery, probably, that we cannot even see on the MRI. We cannot really get excellent margins in the insula where our functional limitation is clear. But still, you can get very good result as long as you have a lesion. So, I think you already sense my philosophy. My philosophy is such that, I would approach the insula, with the resection and, with a ablation if I have a clear lesion. Or it's something that I can go after. And I'm sure Professor Dufour will show you wonderful, approaches of the work that he has done, in the insula. And of course, there you have low-grade gliomas and tumors, which gives you a clear target. With the epilepsy, it's more difficult. And you cannot, be too aggressive here where you don't have a structural substrate. So that moves us to the next topic, which is really beyond resection and ablation. And what is really the problem? That many localized patients do not really get resection or ablation. Because why? Because either we have a bilateral focus, or we are in cortex which cannot be removed, or it is really a part of a much larger network that we cannot really access by complete, resection. So it's too large for complete resection, or it can be multifocal. And, the cost of delaying intervention is, things like SUDEP, unexplained death in epilepsy, kills 1 in 150 people with epilepsy. And I had patients waiting to have epilepsy surgery and unfortunately succumbing to SUDEP. It's a terrible feeling to really have a patient who is this kind of situation. You lose many years of quality of life, delayed intervention, all because of this limitation of epilepsy surgery. So RNS, as you may know, but it's not available, of course, out of the US, you can now connect this to two leads. It can be either subdural leads or an SEEG type, depth lead. There is a control unit which is embedded in the skull, which can be connected, to this, and it looks like this, and you basically can get continuous EEG, and you can stimulate based on a closed loop situation. So here you have an example of this where I put some subdural strips, so when these are connected, everything is closed. This is what you really see, on the MRI. You can see where you have an electrode. You can have, electrodes which are widely spaced or very closely spaced, and this is actually how it looks. Of course, it's nicer in my mind, the DBS, because DBS, you got it in the chest with cables in the neck. A nightmare. I don't really like it, so I like this technology. The batteries now are good for 8 years. So as a surgeon, to do a replacement is a 20-minute procedure, which is just a scalp, because you have a tray which you put instead of a small craniotomy. So it replaces the bone in that area of that size. And the control unit, the battery, just latches into that area, okay? So what you have is this situation, the neurostimulator is here in this space, okay? Essentially in the epidural space, right? Connections here, everything is internalized, and you got a remote system where you can have patient data, served brought to different centers, analyzed, over, a secured network with a neurologist, being able to manipulate it. And what you actually have a situation where you have, normal brain activity, suddenly an unusual activity is identified, and there is a treatment in the shape of, 5 pulses, which are done, and then, then you have continuation of monitoring. Now, so what it can actually record are really both interictal activity and ictal activity, as well as long-term baseline. So, many people think that it only acts on ictal, but not at all. I mean, we have patients where these things goes into stimulation 1,000 times a night, just because you identify interictal patterns. So it essentially also over time really modifies the network. And we'll talk about it, but it's also a fantastic tool to really observe your patient and see patterns. Like, for instance, there are patients who have seizures at certain time of the day, diurnal patterns. So you can learn a lot even for just having this device, which really monitor your patient. So the indication now is patients who are older than 18, but of course there's an increasing off-label use in pediatric population, patient failing 2 medication, have partial onset seizure, maybe with 1 or 2 foci, a patient who are at risk for neurological deficit, don't want ablation or cannot have an ablation or resection, or patients that have not achieved adequate control. And the approach really that you can have targeted stimulation to certain area when there is a clear focus, either 1 or 2, or you can try and modify the network in bigger areas. Okay, and there are today even combination that I do with resection and RNS. So I can take what I can take in a resection, and if there is an area that I cannot take, like primary motor, then I will put an RNS there. And today, I mean, there's a lot of studies going on. It's a very evolving area, but there is also corticothalamic stimulation with RNS, where one electrode is in the thalamus and one in the cortex, trying to really affect the corticothalamic network, really. The long-term results that people have published, you're really getting in terms of once you get to 9 years, you can get really to 75% median reduction in seizure frequency. So the fact that we have a long-term improvement means that we are probably modifying the network, and there is a small percentage that can even get seizure-free. But I always tell my patient, listen, it is not necessarily a seizure-free tool, but it can help a lot. So in terms of what we've done at UCLA, I've done over 160 cases, of RNS. I use it often. UCLA have done over 200, and what we see is really that we have essentially 65% who are responders, meaning they are getting over 50% improvement, in seizure frequency, and also substantial improvement in seizure severity. But about a third, are really super responder, meaning that they've got a 90% improvement. And we're still learning. And I think we will probably get even better with that and identify really long-term result. What about insular or RNS? That would be the last topic here. And so we have had, in that period of time, 14 insular RNS patients total, ages of 18 to 50. 35% of the patient experience a greater than 90% seizure reduction. And, if you look at this patient, you can see, patients who actually got greater, than 90%. And, there was one patient, out of 14 who was seizure free. But again, once you really get to these numbers here, patient really feel a substantial, difference in seizure. Now, there also been some patients that we implanted RNS bilaterally, and we found out that all the seizures are coming actually from one side, and we went on to do a temporal lobe resection, with seizure-free outcome. So there is also the added value of long-term monitoring, which gives you an option to do something more aggressive, recently. So conclude with one example, a 39-year-old right-handed male, seizure onset age 23, again, sensation of throat tightness, followed by confusion, shortness of breath, right facial grimacing, right leg extension, frequency of 16 to 30 a month. This is a very sick patient. And basically, failed medication. EEG interictal, no spikes. Ictal was F84, which means, okay, it's on the right side, frontotemporal, but the MRI is normal. The PET shows general sort of opercular temporal hypometabolism. The MEG, showed several sites, right STG, right insula, right inferior temporal gyrus. Again, not enough to really do anything definitive. And of course, there was also language fMRI. So what do? We cannot do anything without actually going into, okay, so here's the MEG. So the MEG, what is the advantage of MEG in this situation? It gives you some targets that you can implant. So it sort of limit your targeting. And so you increase the probability of finding something useful. So we did what we call a phase 2, a depth study. We put electrode in the right middle hippocampus, amygdala, entorhinal cortex, orbitofrontal, posterior insula, mid-insula. We put also on the other side, although most of the suspicion is on the right side. We believe we need to put a few, one on the other side, both, because there may be a very spread insular spread of the seizure, and also to differentiate mesial from lateral neocortical seizure. In the lateral, the spread is much faster. So interictal, we really saw a lot of things in the RPI and the RMI, and the ictal was actually what we sometimes see in the insula. Unfortunately, right posterior insula and middle insula, simultaneous onset, which preceded other areas. So, you don't have a lesion, you have, it's coming from the insula, but of course. What can we do? So this is a classical case, where, we basically end up, implanting RNS electrode in the, this is a, posterior insular targeting, and here the right middle, here, right operculum, which was also implanted here, in what we call an OPR-AI, meaning we sample the operculum, but we also, get into the anterior insula. And, we could see the onset of the seizure here. You cannot read it here, but it was mainly MI and the PI, middle insula and posterior insula. So what happened here? We basically implanted the RNS, and there are two leads placed in the right insula, one posterior, one middle. Stimulation was enabled with a lead-to-lead configuration. What does it mean? We stimulated from the middle insula to the posterior and created this volume, of network. As of the last, follow-up, a patient reported greater than 90%, reduction in seizure frequency. So it's one every 3 months. Remember, this is a patient who got, 20 to, 30 seizures a month. So obviously for this patient, this is really a major improvement. I'll just end up with one comment very briefly, saying that both ASE, and RNS present fantastic research opportunities, both to study epilepsy, to study network approach even to other disorder, especially neuropsychiatric, depression, OCD, PTSD, even obesity, and of course, pain. And also epilepsy is a window to brain mechanism. Remember, I told you that we can record from single neurons, okay? So here you have an example, briefly, we presented all these visual stimuli, and you can see, this is the, action potential, the spikes, that in response to all this. So these are very responsive neurons. And when you go to the posterior insula, this is auditory stimulus. So you can see auditory responses in the posterior insula, as you would expect, because of the connection probably to auditory cortex. So I think, the insula is an unknown territory. And the advantage that we have with SEEG of studying the insula is incredible. In addition, we have the incredible ability, now that we have RNS in patients who are walking, 24 hours, they're at home, you can study a lot of basic issue in neuroscience. This is a study done by Nancy and Susanna at UCLA, with Zara Jajan, looking at, what happens when you walk, that you have certain patterns, which are associated with walking. And there is a whole technology which you can attach to it, which enables you to monitor really cognitive function and motor function when the patients are at home, and presenting stimuli with virtual reality and augmented reality. We have taken this opportunity that we have electrodes in the brain to really try and move even to areas such as memory, and having, a memory prosthesis. In this article in the New England, we implanted electrodes and showed, for epilepsy, of course, but showed that it also can enhance, memory function if you actually stimulate in entorhinal cortex. And recently we have shown that during sleep, using closed loop, just like in RNS, we can enhance the synchrony between hippocampus and prefrontal cortex, and really enhance the consolidation of memory, in the brain. And why are we doing it? Because we hope that with all this knowledge, we will develop a memory aid, just like a hearing aid. We'll have a memory aid that we can implant and will help, people, with memory problem. And I don't need to tell you that we are approaching a cognitive tsunami, where so much, of the elderly population, will be impaired cognitively. And this is, one of the, approaches. So I will end up just with a general comment, which means that, we get a lot of technologies. And whenever we use technology, we can have an initial period of overuse and enthusiasm. We eventually will gain knowledge, and hopefully, we eventually reach a balance. And, we should avoid, we should always remember that if you have a hammer, everything looks like a nail. So we have a lot of technological options today for epilepsy patients, and we have to use them judiciously. So thank you for listening. I really appreciate this opportunity, and we'll be happy to take questions.